moderator for this session. I think we will get started since it's 9:01. So welcome to this session titled A Dialogue on Decolonizing Global Health. Of note, we initially thought this would be a debate, but in talking and preparing for this session, it was felt that, there is not so much of a debate in this question. It's more, most of us agree that there might be a problem or there is a problem of colonization or a need for decolonization, hence the title Dialogue. So I'm proud and honored to moderate this session. Again, my name is Chemtai Mungo. I'm a gynecologist and postdoctoral fellow at the Bixby Center for Reproductive Health at the University of California, San Francisco, which is part of the GloCal Consortium. I'm a proud alumnus of the Fogarty Fellowship. And like half of you fellows, I was born and raised in sub-Saharan Africa. I did my undergraduate and medical training in the United States and recently finished a residency in obstetrics and gynecology before embarking on my global health research career. My work is focused on increasing access to evidence-based cervical cancer screening and prevention amongst HIV-positive women in sub-Saharan Africa. I bring my perspective to this dialogue as a LMIC-born early career investigator who has lived in the United States for about 15 years, and in that time navigating academic global health from this lens. Like many of you LMIC-based fellows, English is my second language. My grandparents never went to school, and my parents did not go to college. Hence, my perspective and your perspective as LMIC-based fellows in global health is different from what is seen as an epitome of career success in academic global health from a Western lens. As an early career investigator in global health, I've had many successes. I've gotten grant funding, including from the NIH. Last year, I was named a young investigator through the ASCO Fellowship, and was recently given an offer to join a top academic global health position as a faculty member. However, I have also experienced significant challenges working in this field that centers a Western lens and centers the experience of those who come from countries, Western countries, even though the field is supposed to work on issues around the global South. And this reflects the need for this conversation or this dialogue around decolonization. So we have two excellent speakers today that I will briefly introduce before we get started. Dr. Senjuti Saha is a molecular biologist and an activist based in Bangladesh. She's a scientist and director of the Child Health Research Foundation, where she works at the intersection of molecular biology and public health. After completing a PhD in molecular genetics at the University of Toronto in Canada, she moved back to Bangladesh to work on the front lines of public health, focusing on preventable pediatric infectious diseases. Among several projects, Dr. Saha is currently leading a large study on tracking SARS-CoV-2 variants in Bangladesh and looking at the immediate and long-term impacts on Bangladeshi children. Her work is grounded in advancing health and research equity in Bangladesh and beyond. She's an associate editor of the British Medical Journal and an academic editor of the PLOS Global Health. Our second panelist is Dr. Eugene Richardson, who's an assistant professor of global health and social medicine at Harvard Medical School and also an attending physician there. He has previously served as a clinical lead for Partners in Health Ebola response in Sierra Leone and continues to conduct research on the social epidemiology of Ebola virus and COVID-19. He has also worked in clinical case management for the WHO's Ebola response in the DRC. Dr. Richardson's focus is on the biosocial approaches to epidemic disease prevention, containment, and treatment in sub-Saharan Africa. As part of this effort, he's a chair of the Lancet Commission on Reparations and Redistributive Justice, and is the author of the book Epidemic Illusions, which will form part of our discussion today. So a big question that we are dialoguing today is, what is wrong with global health, and why does it need decolonization? We're focusing our discussion on this book, Epidemic Illusions, authored by Dr. Richardson. As somebody whose English is a second language, I'll have to echo many people's frustration that this was a very difficult book to read because of the complexity of the language. However, it's a book that's very critical of this field that we all love and are very passionate about. I will use a summary from a fellow, Cosmas Mugambi from the Ministry of Health in Kenya. He summarized this book as such. Richardson demonstrates the ways in which the flagship discipline of epidemiology has been shaped by the colonial, racist, and patriarchal system that had its inception in 1492. He asserts that the biggest epidemic he has encountered is not Ebola, but the epidemic of illusions transmitted by the coloniality of knowledge production. The continued disparity in communicable diseases between low-income countries and developed countries is not as a result of the inability to control the problem, but rather due to contemporary imperialism and a matrix of neo-power that results in inequities in global health. The world has the resources to prevent all these senseless, tragic deaths, but this is not happening. So Cosmas Mugambi from the Ministry of Health summarized this book as such, and I would like to open the floor to our two panelists. From your experience, what is wrong with global health and why does it need decolonization? Dr. Richardson, you can start.
Okay, thanks so much. It's an honor to join all of you today. I myself was in a similar spot to many of you about 14, 15 years ago. I went with Doris Duke on a year off med school, and it was a very formative experience. And so I'm excited for all of you and excited to learn from you later and to be colleagues in the future or sooner than that. I guess to a quick summary, thank you to those of you who had a chance to skim or read the book. I guess to sum up my position, it's not really my position as you see from the book, it's kind of recycled from learning from a lot of Global South scholars, is that much of what we do in the field of global health, I think, tends to perpetuate the very inequities we're trying to solve. And, we can look back as far as Kwame Nkrumah from the 1960s, who said that aid is a revolving credit where a little bit is given with one hand to continue the huge amount of extraction that's going on the right. And so for the data for that claim, Jason Hickel recently published a figure that there's been a net appropriation of $160 trillion from the Global South since 1960. There's no development going on, right? There's no excess wealth in the global North that's being shared to help countries. There is continued extraction that has started in colonial times, continues now, and it's just disguised in different ways. And when I first started out in global health, I saw the ways that aid and humanitarian work kind of disguise this, exactly what Kwame said, giving that little bit and that amount's coming out. But what I started to realize when I worked in the field was that what we actually call the global public health science, what we actually do in research, aids in that obscuring, helps with the whitewash of what continues to be taken out. And so that's what the book is about, to show how much of what we think of as epidemiology or public health science, especially when it comes to human and social behavior. I'm not talking about, Chemtai's great work where, we know that viruses cause cervical cancer and vaccines prevent that. That's all kind of biological, physiological. But when you get into the human science realm, the social inquiry realm, there's no hiding the ideology that you bring to the table, because it determines what the variables you choose, the methods you choose, the interpretations you take. To look at it the way Paul Cilliers does, who was a who was a philosopher from South Africa, anytime you're trying to understand complexity, there are always normative decisions to make or ethical decisions because you're reducing that complexity to understand it. And by reducing it, you're distorting it. And you never know through your distortions which of the variables you choose are actually important, because they're nonlinear. So the littlest thing that you leave out could actually have geometric ramifications as you go. So you're making decisions that distort, and these decisions, if you go, and this is what the book does, goes through plenty of examples of public health science that distort in favor of neoliberal interests, in favor of elite interests. They rarely take into account the social justice or reparative interests of the people we're working with. And so the call is for, by really transforming the way we do global health science and transforming representations, we can actually get more towards this reparative idea where, if you're working in India and you're agonizing over the vaccine situation, you realize in the background that $45 trillion was stolen from the UK during the colonial period. Now, we'd not be having these conversations about, vaccine apartheid, at least in India, if there had been repair of that legacy, if there had been reparations of that, 45 trillion, which is many times the amount GDP of UK currently. So I look forward to the discussion, but I guess that is it in a nutshell. How is what we do in global health infused with ideology? How does it how does it perpetuate status quo relations of transnational inequity? Thanks.
Thank you, Dr. Richardson. Dr. Saha, please go ahead.
Thank you. Just such a pleasure to be here and to be, being a Bangladeshi, being invited to this international panel is definitely an honor for me. I wanted to take a couple minutes first to describe my position. And I want to make it very clear that everything that I'm going to say is a viewpoint, is a personal viewpoint, maximum viewpoint or perspective of my team that I work with in Bangladesh. Absolutely nothing more than that. I'm Shail Jyoti. I am a Bangladeshi. I was brought up here. After grade 12, I went to Canada. I did my undergrad in biochemistry, and then I did my PhD in molecular genetics that you've already heard of. When I was in my second year of PhD, I was diagnosed with cancer. I think I'm alive today, and I'm here in this panel today because I was in Canada, because I had access to health and universal healthcare. Either I would not be alive today, or if I were, I or my family would be bankrupt. So when I finished my PhD, I made the decision of coming back to Bangladesh because I was privileged enough to go and learn and perhaps gain a little bit of knowledge. But I wanted to use rest of my life to learn more and share whatever knowledge I had gained and do something for the public. Let me be very clear. I have no global health training. Here, I work in the intersection of public health from experience, and the intersection of public health and molecular biology, all from experience, and because I work with an amazing group of community workers. I have no degree in global health, and I constantly struggle to understand what global health is, because very honestly, this term of global health, I only come across when I interface with my global North colleagues. In Bangladesh, we work on improving public health. We have no time to think about global health. We can barely get through today, and we don't know if we'll make it till tomorrow, or if the child in my hospital or seeking care at the NGO will make it to tomorrow. So we can't contribute to global health. I don't understand global health. I wake up every morning. I work extremely hard with my extremely dedicated group of 350 people, many community workers in my NGO, and we do whatever we can to improve life. We don't understand a lot of theories. All we know is that every day we have to go a step forward. In this process of working in Bangladesh and moving here and learning from the country. I was brought up here and I've been here for 5 years, but I was not here for 11 years in between. So I'm actually trying to learn. And there is so much to learn to understand the context. So in this process of also, seeing the difference between my experience in Canada and then my experiences in Bangladesh, and realizing the stark differences in whether access to health or access to the benefits and practice of science has somehow made me a very, very vocal activist in Bangladesh. And to some extent, I've also become a public figure over here. My position today is that inequity in health outcomes is a deep, deep multi-sectorial problem. Colonialism is not a problem of only health. If we think solving global health will solve all health inequity problems, I think we are limiting ourselves. We are setting ourselves for failure. There is a lot more other than global health. When I talk to my global North collaborators or my colleagues, it is often put forth, global health is often put forth as a discipline. And that to me is very confusing. It may be for my colleagues in Global North. And as I said, it is not for us. I rather think that global health is basically a collection of problems that are discussed by my rich and or white or my Global North colleagues and many of them really, really strive to achieve equity. And those are the people who are working with this set of problems. It's also a collection of problems that has been decided to be problems by my Global North colleagues. The solutions are funded by my Global North colleagues and also approached by the Global North colleagues. Again, people like me are way too busy in the local context to think globally. We are still struggling to understand and solve problems locally. Over.
Thank you. Thank you both. A lot of things to ponder. So global health is a collection of problems amongst people who are striving for equity. And, like most of us who are kind of interacting in this field of global health, whether it's a field, etc., I think at the core is a desire to do better or to do good. But as Dr. Richardson book illustrates, we are trained as epidemiologists or to think of the more proximal the issues, the epidemiology, what can we put in the equation? So as trainees, as these fellows are getting out there, it's very easy to write a model that looks at very discrete concepts. And most of us are not trained to really understand social justice and the historical causes of why we are where we are. So how can the field, and like was said, epidemiology is thought to be apolitical. We're as scientists, it's felt that you should not be an activist. So maybe even like that activism could be looked upon differently or maybe frowned upon. How can fellows start to think and bring in the concepts of the historical causes of inequity in understanding and starting to change how we are defining this field and what kind of questions we are asking, and whether or not we should center reparative justice? Both of you, what are your thoughts on this?
Thanks again, and thanks to Senjuti for reminding us that our position is also important from the framework we start with. And so mine is one of a white upper middle class cisgender male settler colonist, and then in the book I add a privileged exerciser because it's one thing to my PhD is in anthropology. So it's one thing to go the old school route and say you're going out to represent someone else's or some other group's experience of the world. And I think the book for me was more about representing the circles that I'm a part of, how epistemic violence is committed, because I'm part of it and I have the firsthand view of it. As far as what we can do to incorporate some of these ideas into our training, this was the idea behind the University of Global Health Equity in Rwanda. It's a partnership between the Rwandan government and Partners in Health. And it's a medical school. It's a social justice medical school. Incorporated into the curriculum is the idea that social justice is not some sort of kind of fringe discipline, or is separate from what you should be learning to practice medicine. So I think we can learn from that model that that dividing what we do as practitioners from what is political is actually, the most political stance of all. So, how did I put it down here? The quote that from Horkheimer and Adorno back in the Dialectic of Enlightenment, that attempt to avoid politics in the name of remaining free of values is the most political stance of all. Right? It's like Switzerland during the World Wars. Right? By staying neutral, you're actually supporting the Nazis. Like you can't claim an apolitical position, because that position has ramifications for perpetuating the status quo. And so I'll go so far, to say that studies, analyses, and my critique of the Institute for Health Metrics and Evaluation and their COVID forecasts go so far as to look at them as being racist, because they do nothing to decrease disparities. They do nothing to add to the social imaginary that, how can we reduce inequities? They just perpetuate status quo. And by perpetuating status quo, you are doing political work. You are doing racist work. And so I'll point you just quickly, if you're interested, to a paper we recently released in Social Science and Medicine called Reparations for Descendants of People Enslaved in the US and its impact on COVID transmission. And we actually, did what we thought of as anti-racist modeling. What would it look like to incorporate into what we do as status quo epidemiology, anti-racist elements? And we basically found that the country could have 30 to 60% less COVID right now if we had enacted a program of reparations 10 years ago. And so these are the sort of things we can do, moving forward, try to incorporate to break the mold of conducting research that contributes to the status quo, to try to find ways of incorporating anti-colonial, anti-racist elements into the research, to find ways of parameterizing farther upstream, so that there is a justice element to the work we're doing. And this doesn't pertain so much to the basic science, right? To me, there's nothing ideological about the basic science. But right when you get into the realm of social phenomena, human behavior, there's always going to be, again, those ideological presuppositions. So recognizing that and our attempt to recognize, to be reflexive about it, and to try to move, in this case, COVID modeling into an anti-racist realm. That paper was an example of it. Our next one is on environmental racism and COVID. How, if you trace, redlining in the past to how people of color have been segregated in cities, and then they are now in a position where they suffer from, poorer air quality. There you have a historical legacy that determines the air people are breathing, that determines actually higher incidence and higher mortality from COVID. Are showing about probably 15% of COVID mortality comes from air pollution alone. And so walking things like that back, not just saying, oh, people of color seem to have a higher incidence in mortality, and then reporting that. That's kind of the tallying that just continues the status quo, doesn't understand why. You walk it back, you start to see, oh, you know what? Redlining wasn't just unethical. So redlining is where, after World War II, people of color weren't getting mortgages. They were assigned to the poorer parts of cities. that has consequences in health. And so to fix those, it's not just about cleaning up the air, it's about repairing those legacies. And that's what we mean by reparative justice, whether it's in the form of eradicating the wealth gap between Black and white people, whether it's urban renewal, because we see that those redlining effects, the effects it has on things like COVID mortality. So bringing those structural determinants into our analyses, I think, is a start. In trying to support reparative justice in all its forms, that's a further step. Over.
Go ahead, Saha.
Okay, so let's first start with activism and being apolitical. I am a very, very proud activist. My parents are not proud of me, probably, but parents are never proud. They're so hard to please. And I want to talk a little bit about activism and being an academic. At the same time over here, because we use the term decolonize once, I think already, or a couple times. Mm-hmm. So, my idea of decolonization or decolonizing global health, because, I think the first conference on decolonizing global health was actually arranged by Harvard University. And I was trying to understand what's the Bangla word. Bangla is the language you speak in Bangladesh, of decolonize. There is no Bangla word for decolonize. So, again, it's a term, decolonizing global health is a term really used mainly by my global North colleagues, but it's a really, really important concept. So when I try to learn more about it, there's of course a lot of readings we can do, but I like talking to people. So I started talking to my grandmother, who has lived through partition in India, who has been through decolonization. I talked to her. I was like, there are parallels. Parallels are constantly drawn. Can you tell me a little bit about it? Because I want to be part of this movement. And she was shocked that decolonization is becoming such a common thing that people talk about, because decolonization is a violent affair. When, I won't say the British left, when the British were driven away, lives were sacrificed. There were fights, there were wars. It wasn't a tea table conversation when the British said, hey, come, let's have afternoon tea and let's talk about, what are the problems and let's solve them. A lot of it was actually, almost all of it was driven by the oppressed. They were activists, they sacrificed lives for the greater good. So I think when it comes to really, fixing problems, I don't like using that term because we cannot fix problems. We can work towards solving them gradually. But when it really comes to decolonizing global health, it requires a lot of activism. It requires a lot of sacrifice from the global South, because we are the oppressed, but also a lot of support from the global North, right? We need colleagues like Jean with us, because sometimes to the young listeners over here who are just starting in the field, I would say, if we are part of the global North community, sometimes it's okay to lean out, make space so that our global South collaborators can lean in and raise their voices, and we make space for them to be heard, not use our voices in the global North for them to be heard. That's one thing that I wanted to talk about. And I think, Chemtai, you were also asking a little bit about epidemiological tools and their use. Yeah. So there are definitely, like as Jean has very beautifully said in his book and touched upon now, how epidemiological tools have been used to serve the needs of the oppressor. However, I also want to show you another side, because I am a molecular geneticist and a biologist, and I actually use epidemiological tools locally. There is a vaccine called the HIB vaccine. All of you probably, most of you have received this vaccine. Haemophilus influenzae type B vaccine. It's in the part of the program, National Immunization Program in all developed countries and in most of the global South countries now too. Bangladesh introduced this vaccine in 2009. This vaccine is now estimated to prevent deaths. I'm not talking about cases, I'm talking about deaths of 3,100 unborn children every year, just in Bangladesh. It took us 21 years to get the vaccine after it was licensed in the US. One of the reasons we didn't get it, of course, neglect is one. And we will talk about it again and again throughout our time here. But one of the reasons we did not get it is because we did not have data from Bangladesh showing that pathogen, Haemophilus influenzae type B, even causes disease in Bangladesh. So we had to work in the laboratory, transfer the technology, work in the laboratory, and show epidemiological data of the burden of the disease so that we could actually convince policymakers to get us the vaccine. And after the vaccine came, we are still working with policymakers because we have competing priorities. Policymakers have to decide, do I bring that vaccine or do I send children to school? So we are using epidemiological tools to show the vaccine works. It is saving lives every day, right? That's also a use of an epidemiological tool. So that's a good use. However, we are seeing, with big data and other, global burden of disease type of papers, we're also seeing other uses of epidemiological tools, and it has definitely become a problem. But I don't think epidemiological tool is the only problem, or I think it's more of a symptom of a problem. Epidemiological tools have existed even before global health existed, right? So I think it's just a symptom of the problem, and it depends on how we use them. I think the biggest problem of who gets to use epidemiological tools how is based on their position, based on their power. It's the power struggle of using the data from those epidemiological tools, or what data you're generating based on those epidemiological tools. So at the end of the day, I think it all comes down to power struggles between groups. Over.
Thank you, Dr. Saha. Power and who has the power? I think that's a global problem, in particular, who gets to define the questions that we ask and who sets the agenda for research. There's a question from a fellow. In terms of strategies to decolonize epidemiology research, what level of power would be most impactful to target? Funding mechanisms, implementers of funding, as we try to move and to address these questions, where should we most target, which levels of power that are driving these inequalities or this persistent racist or colonialist mindsets?
Yes, thanks again. I'll quickly respond to this one question about the complicated language of the book, which is absolutely correct. I mean, part of it comes from my taking this ironist approach, which is an approach that tries to get away from, the idea that there are objective ways of describing things. There's many viewpoints. And so to disrupt that, to show that there is a failure of all kind of sophisticated conceptualization, I try to hit it from a bunch of different angles. But in doing that, I make things, hyper jargony. I mean, part of that is my being co-opted by the academic path, and needing to produce a first book that can be used for tenure packages down the line. But the idea of suggested of making it into a graphic novel, I thought about that for a second book and actually like turning it into zine form or something like that, so that it can be accessible in different ways. But for me, understanding the co-optation by the academic path, but also being pretty, I guess, Wittgensteinian in that I think that there's a problematic nature of language, that you can never come to discrete descriptions of phenomena. And so that's why each chapter is a redescription, trying to hit it from various angles. So yeah, not really a defense, but it's sort of that was what was in the back of my mind. As far as where to hit power, Seye Abimbola, who is the editor of BMJ Global Health, has talked about going as far as abolishing global health, right? Is it possible to just reform these things that we're doing? And so again, I think this is not so much talking about the basic science that does the good work of coming up with vaccines and finding out that masks prevent infection and all that kind of stuff, but is this aid system, functional? Why would it take? For me, what we look at is not, how the vaccine was created, but why it took 20 years to get. Like, what are the mechanisms that made it so that it took 20 years to get it to Bangladesh? And if we look at, something like Churchill's role in the Bengal famine, back in World War II, and reparations for that, what I had mentioned, Utsa Patnaik coming up with the total of 45 trillion for India. If these reparations had been paid, would we even be talking about any of this? I don't think so. And so that's why going the reparative route may make a lot of these conversations moot, because the resources that actually belong to the places will have been returned. The things that have been stolen will be returned, so that we're not having to participate in this strange game of charity. Over.
Thank you. Dr. Saha, do you have any thoughts on which levels of power we could start to target in changing the questions that epidemiology is asking, or in trying to move our field towards, a decolonized mindset?
Yeah. So, as Jean was also saying, the most proximal thing to target at the moment is funding and aids, right? And this is for both. We have Global South has some responsibility. I am sorry, I say we sometimes. I shouldn't be. I don't represent the entire Global South or all LMICs. Global South has a lot of responsibilities. Global North has even more in some cases. And, as Jean was saying, that it's epistemic, right? It's not only what's happening, it's also in our head. It's how we define things, how we think about things. When I try to, fight inequity in Bangladesh, I'm not only dealing with my Global North donors or my Global North collaborators, I'm constantly also dealing with the colonial mindset in Bangladesh itself, where many of my colleagues will prefer to work with, a white colleague with much less experience than me, just because for centuries we have portrayed white people as better, as more knowledgeable, etc. So I think there are many, many aspects that we have to target, and changing mindset is difficult. It took centuries to get to this mindset. To repair that, it will probably also take centuries. But, of course, targeting funders and abolishing funders to some extent is a great idea, but will it work? Probably not. Abolishing funders will only work when there is absolute equity in everything else. Abolishing the Gates Foundation, for example, is not going to help global health get rid of inequity, because if there is no Gates Foundation, there will be something else. Before the Gates Foundation, there was Rockefeller. So maybe it will be worse. Maybe it will be Jeff Bezos who will take over global health with all of his money. So I don't know. I don't know how to target. I don't know what the solution is, but I'm so glad that we are having this discussion. At the end of the day, as Jean was saying again and again, it comes down to reparations. If we really want to achieve equity, and if we want to balance power, it will come down to reparations. Countries, governments have to take action. Just going after some donors, multi-billionaires, is not going to help. As Jean was saying, it's trillions, hundreds of trillions of dollars that need to be given back for reparation, right? So all countries need to come together for that, and I don't know if that is possible or not. I don't know how we can repair, very honestly. So glad to have this dialogue. I don't have a solution.
Thank you. This is a dialogue that will take the next 400 years to repair. I think the last 4 minutes before we move to the discussion in small groups where many of the questions can be addressed, I would like to leave this thought of reparations and repair to both ourselves as fellows or early career investigators, and in particular to the leaders of programs like Fogarty. How does academic global health think about reparations and repair? Do we even, I think we agree that, there is a need, or maybe we don't, but if we do, what could it look like as we start to think about how we can change, the funding mechanisms? I posted an article about the case for reparations in the United States context. And, I just want to honor the fact that last year, George Floyd, who was a Black American man, was killed, and that kind of precipitated this racial reckoning that also kind of, kind of tailgates to this decolonizing question. And, academic global health, we are funded primarily by the NIH. This book talks about some of the issues with how funding is allocated, with very little allocated to clinical work, clinical care, or service delivery. So how could reparations and repair look like within academic global health? If you'll have a response within a minute, and we'll continue this conversation in our small groups.
Thanks again. So yeah, I think, the question popped up too about how anti-racist was that modeling paper. And so, for example, it's being used by Mary Bassett, who was the former head of the New York Public Health Department and is now a professor at the Harvard School of Public Health. She's convening more advocacy reparations type group to start to try to translate some of the work like that into kind of more policy advocacy. But when she told me about it, she's like, I was surprised to find that yours was one, or ours was one of the few papers that we could actually use. And so that to me was, all right, the call needs to go out to colleagues like you out there to get some more of this work out there so that it can be used as a lever in doing the advocacy work. Because there's a lot of good advocacy work, but it doesn't seem like there's a lot of good justice focused, at least as far as in the reparative realm. The other thing was, let's see, and then I guess, yeah, using things like the University of Global Health Equity again is sort of to the people that have founded it, they see it as reparative work to try to put all these ideas we've been talking about and operationalize them in the training, in the clinical work. But of course, we have to, go a lot farther than that. The group that we have that's working on DRC, the trillions that the Belgium and the US owe, how much would we be talking about COVID problems there, measles epidemics, Ebola outbreaks, if 93% of the mineral resources weren't continuing to be funneled out of that country and repair of the last 200 years had come back in? So there are things to think about. How can our work support these ideas? If the 1800s were a century of abolition and the 1900s were this century of aid, development, and human rights discourse, it's possible that there is progress, and maybe the 2000s are a century of reparative justice. Over.
Thank you. Dr. Saha, you have the last word. What does reparation and repair look to you from where you sit?
To me, it looks, because I know big changes are hard right now, to me at the individual level, reparations look like a real friendship. When I work with my Global North collaborators, or when you become big scientists, and all of you will, and let's say from the Global North, whenever you're working with the Global South, individually always think of capacity. Because of the centuries of exploitation, there has been an there hasn't been as much capacity built in a lot of our countries as there should have been. So every time I know you work with your Global South collaborators in any of these countries, think about what capacity can be built. If you're working with them, what are you leaving back and how you can be made indispensable, right? Always keep that in mind constantly, and also keep in mind there is so much to learn. Take some lessons away. Don't write a book on the lessons that you learn from a country that you have visited, but take all of those lessons away and remember that we need to lean out sometimes. Thank you.
Thank you all so much. And this conversation and dialogue will continue for years to come. Dr. Shail Prasad will take over in small groups.
Hi, folks. What we're going to do right now is we're going to break up into small groups. We have folks from the different consortia who are going to serve as moderators for these small groups. And then at the end of it, we are not going to come back to the large group. We wanted to spend enough time in the small groups to have a robust discussion, but we're not going to come back to the large groups. All right? And Yolanda will send us our way